a lift, and once out of the building, please gather outside the Yorkshire Bank on the opposite side of the road. Exit by the door of which you entered the room by, and if you need any assistance in evacuating the building, please make yourself known to a member of staff. Please also make sure all your mobile phones are turned off or set to silence. And I'm to advise the meeting or part of the meeting will be recorded for future broadcast. Apologies. Minutes of the meeting of the 6th of April. Members happy for me to sign it as a true record?
Agreed.
Declarations of interest. Any member got any declarations of interest that aren't already recorded in the minutes? Councillor Constable.
As we're mentioning outdoor activities and clubs, I am a member of walking and cycling clubs in the town. Obviously not in an official capacity.
I'm Director of Volunteer Centre Nuneaton and Bedworth, and also Director and Founder of the Scrutiny Education Programme on Substance Misuse.
Any other member? I've put my own declaration interest because in Kevin Hollis's report it mentions Wembley Community Centre as my director. Public consultation, where I've been made aware that Mrs Condacor wants to speak on items 6, 7 and 9. Andrea Green, who was presenting 6, isn't here yet, so we're going to move straight on to the public health by Dr. Lennon.
Okay.
And then after the
Right. Thank you very much for inviting me along. It's a pleasure to be here. I have a short presentation which I have to admit I got a little bit carried away with, so there are more slides than I would have liked, but that's what happens with PowerPoint, but I'm going to rattle through them. Most of the information you should already be aware of. And I know there are 1 or 2 specific things you wanted to talk about, maybe the JSNA, but we can do that at the end. So, I just thought I'd put up the vision, our priorities, the public health priorities for the county. And these are these cover everything really. And the issue about public health, and particularly the work we're trying to do, is that they all link in. So, for example, if, as Kevin will talk about later when we're talking, and the work we're doing together, which is really good work, about improving physical activity and getting people more active, that of course improves mental well-being as well as any impact on diet. So, moving on in terms of then Nuneaton, the overall outcome, you know, whatever we discuss in terms of process outcomes or activity, is are we living long, healthy lives? And you can see there that Nuneaton and Bedworth, and these are the figures for the last 6 or 7 years, people in Nuneaton, men and women, do not live as long as people in Warwickshire or across England and Wales. And that has been the picture for a long time. The gap had widened and then narrowed slightly, and again the latest figure is slightly wider, but essentially we haven't been able to narrow that gap. And that's due to a whole range of issues. Only about 10% of life expectancy can be attributed to healthcare. It's a factor of education, employment, and all the other issues that affect our day-to-day lives. That's what primarily affects our life expectancy. So as well as living a long life, and as I get older that's becoming more and more important to me, it's also that we live a healthy life. And this shows you the gap across the county in terms of life expectancy and healthy life expectancy. And these are figures from the Office of National Statistics and show that there is quite a gap, quite a period towards the end of our lives when we're not in, we would describe ourselves as not in good health. But even in terms of across the borough, there is variation. So you can, so it's not just between the north and the south or the east and west, it's actually within the borough itself. Right. And then that leads on to, well, where can we make a difference? And I've picked out at random, well they're not random, they're some of the key, our top issues in terms of preventable deaths or areas where we can make a difference. So the cancer incidence, the number of cancer cases and the number of people dying from cancer is higher across the north of the county, and we feel that about 300 of those deaths over those 3-year period were preventable. That is deaths in people who are under 75, which if they hadn't been smokers or etc., or hadn't lived in a deprived area where they didn't have access to nutrition or to all the other advantages, those deaths could have been prevented. The same for cardiovascular disease, which is heart disease and stroke. I didn't have preventable deaths for alcohol, but that is a Nuneaton figure. We're seeing over 600 hospital admissions per year for alcohol-related conditions. Obesity in our children, we measure them, those are real figures, and those, as you can see, it doubles between school entry and 10, 11-year-olds. And those figures are higher than the national figure and the Warwickshire figure. And of course that has huge impact. All of this ill health has an impact on the rest of the community, and I just put up one of the carers figures. We have a lot more information, but 1 in 9 people providing at least an hour unpaid care a week. So I want to move on to children, and I've got a number of slides. We know, I haven't got Nuneaton and Bedworth figures, I couldn't get them, but generally our levels of looked after children in Warwickshire are higher than the English average. Deliberate self-harm, so what used to be called attempted suicide, people taking overdoses or mostly overdoses. 237 in Nuneaton and Bedworth, higher than the English average, and Warwickshire as a whole has relatively high rates of deliberate self-harm. And it's going up every year, which is even worse. And then children not in education, employment or training, 87 in Nuneaton. So, and then I couldn't not mention sexual health and teenage pregnancy, which I know this committee has been doing some work on. And the latest figures, it's the second line in the column. The first figure is the latest figure for 2015. There's quite a gap before we get the data. And while it's come down, consistently over the last 15 to 20 years, the level of teenage pregnancy in Nuneaton has been higher than the rest of the county in each of the districts and higher than the national level. And we've seen huge reductions, thankfully big reductions in Warwickshire as well, but even with the reduction, Nuneaton is keeping its place as an area with high numbers of teenage pregnancy. So those last 4 slides were simply to emphasize the point that one of our big priorities is children and young people. And we do need to pay, I think, more attention to children and young people and what's going on with their health. That issue of deliberate self-harm is particularly worrying. That's a tip of the iceberg issue in terms of the whole range of mental well-being and resilience in children. So it's in your pack, I think, the latest profile for Nuneaton and Bedworth, just published this week, as well as the other districts and boroughs. And these are published, as I say, this week for all districts and boroughs and county councils. And it shows the areas, the red ones picked out are where the figures for Nuneaton and Bedworth are significantly worse than the England average. Now, I'm not going to go through them in any detail, but that's there for the committee. Right, so these are the priorities then reflecting that. And obviously we're particularly keen to do work on cardiovascular disease and cancer, and then the underlying factors that lead to that, mental illness and mental well-being, and some of the others then, particularly MEC, for example, are about how do we tackle those. And then you'll know the North Partnership priorities, which again reflect the same approach. And that is just to remind me that there are a whole range of services we offer and are provided by Public Health through the County Council. And many of those are available most of those, or if not all of them, are available in Nuneaton, and most of the services are provided in partnership. So you will hear later on today, or later on this evening, about the Fisher Futures service from Kevin, and that is a partnership very much between the leisure services and ourselves, and is proving very significant in terms of tackling childhood obesity, maternal obesity, so there's a pathway for pregnant mums as well as adults, and in fact we're looking at extending the scope of that service. We also have some small-scale grants which have been in operation now for the last 4 or 5 years, though the pick-up in Nuneaton didn't happen first year. And these are some of the grants which are jointly funded between the Borough Council and Public Health. And that work is about small-scale initiatives and how we can pump prime them. Just one thing, I need to mention this, and this is a partnership again between the 2 districts, the 2 boroughs, the CCG and ourselves, and is proving very popular. And particularly in terms of the priorities, for example, cancer and cardiovascular disease, as well as all the risk factors, this is an approach which could help tackle that, and we're looking at how we could extend it. I just wanted to mention very briefly about the way our service offer is changing, and this is, you probably can't see it, unfortunately it's very small, but this describes our mental well-being offer. And we have a small amount of money, public health budget is very small, but we've used it to refashion our services in a way that is available. And this is available now to everybody who has a Warwickshire postcode. And we're highlighting the fact that at the moment in the libraries across the county, there are a range of books, both you can win a borrow or download, around depression, anxiety, stress, coping with life, dementia, a whole range of conditions. On top of that, we offer access to a web function that's called the Big White Wall, where you can log on and as well as get information, There are chat rooms there, all moderated by a psychiatric nurse and a psychiatrist, and you can arrange online appointments. And of course, this mirrors the way we access information and access services. So that can be accessed in your home late at night. You don't have to wait to make an appointment, you know, as you would with a CPN whenever that's available. And then there are other services, helpline, drop-in centre available also. So that's the sort of way we're looking at how we provide a much more digital offer. I know that's not suitable for everybody, but particularly for younger people, that's how people now live their lives, and far more online. And we need to provide access and support in that way. So I just wanted to mention two specific areas I'm very keen that we enhance our joint work on. One is around the proposed growth and the local plan, and we've been working with the CCG, and we're very keen to extend our work with the Borough Council on ensuring that any developments are as healthy as they can be, or provide opportunities for people living in them to be healthy. The other area is around air quality, and this is another area where we can work together. We have established an alliance which includes officers from the Borough Council as well as Public Health England and the other districts and boroughs. We're promoting and launching an active travel campaign. We're very keen to work on the air quality action plans. And I don't know if any of you heard on the radio in the last week, there was information about anti-idling initiatives which are being taken, particularly in London. And I didn't realise, but I'm told that idling is actually a criminal offence. So that's something that some of the London boroughs are tackling. So there's a whole range of things I'm really keen for the Borough Council and ourselves to work on. So I just wanted to, that's a whistle-stop tour, but I'm really keen that you have sight of some of the joint work we're already doing together, which is excellent. I mean, I keep coming back to Kevin, but that is really important work. I'm really keen that the committee, in whatever way it can through the Borough Council, highlights the work we can do together on improving lifestyle support, self-help support for people in Nuneaton, that we can promote this training. We have a whole range of training packages available, many online, and we're very keen to get staff across the public sector and then eventually the private sector involved in that. And we're particularly keen to have a commitment to continue to work together and hopefully enhance our work on planning, licensing and other areas where the Borough Council has influence. That's the only other thing I put up was just if any of you have time, we're consulting on a number of services. They're out. They will shortly be going out to tender. As you know, we have to put all our services out to tender, and these are the ones at the moment. They're out to public consultation, and health visiting services will shortly go out to consultation. So if you have time and you can log on, I'd be really grateful. We're encouraging people to respond. That's everything from me, except to say you wanted to talk about the JSNA update. These actually haven't gone to the Health and Wellbeing Board yet, so officially they're not ratified, but the report on the JSNA, which I know has been circulated, is a highlight report. It's an annual update, and it highlights the reports, the topic-based reports that have been undertaken. The other report or thing I wanted to mention, and it's also in your pack, are the the different geographies that have been developed between the districts and boroughs, the CCGs, the hospital trusts and the county council, which we're hoping to use as the basis for planning work, particularly not housing planning, nothing like that. This is around how we support communities in terms of community resilience. So those as well have not yet been to the Health and Wellbeing Board, so they have not yet been ratified.
Certainly we will start at all. I have a speaker on item 6.
Thank you. I don't really need to say an awful lot because most of it has actually been covered. And the one thing I was going to pick out was air quality, because on the papers that were sent forward there didn't seem to be much on air quality, particularly on the joint needs assessment thing. So I know Dr. Linnane knows that. That's a very hot topic as far as I'm concerned. And I think it's something that the council really needs to take on board, particularly liaising with planning now. One other thing that came to my mind. Sorry, I've forgotten. No.
Any questions or clarification from members? Councillor Ellis.
Thank you. You said idling is a criminal offence.
Councillor Ellis, it's to the speaker.
Sorry, I do apologise.
That's all right. The speaker said no.
I didn't say enough. I don't think they are against that.
Well, it's related to air quality, and so I'll leave it for a
You're
bit.
leaving it, so, thank you. So, any questions?
Go now. Thank you. I didn't know idling was a criminal offence. You said it was news to you. Can you just tell me more? How long has it been a criminal offence?
Oh, I only heard this on the radio last week as part of an initiative that's going on in some of the North London boroughs, where they're using traffic wardens as well as their normal duties to actually approach van drivers, car drivers in urban areas in particular, who are idling, and asking them if they could turn off their engine while they're waiting.
Yeah, I heard that outside schools and hospitals
Yes.
when they're vulnerable people. Criminal offence, is that?
Well, that's
I
what
didn't
the
hear that.
leader of one of the
Oh,
councils
okay.
said, and it's something I'm going to follow up
Yeah,
on,
okay.
because it's a relatively, I would have thought, a relatively simple thing to do if it has the level of effect that they seem to suggest.
Couldn't quite see the slide on all the services for mental health, and I don't think I've got it here. There's lots and lots of services. It looks like they're all online to me.
No.
You said with the big white wall that you can book online.
Yes, that's all online.
So that's all online.
Yeah.
Would you just be able to have a copy of that?
Yes, I can send. We have.
Send the slides out to
Well, we have posters which should be in every GP surgery, and we've sent around widely. We have 3 well-being centres for mental well-being across the county, one of which is in Nuneaton. So there are drop-in and face-to-face services available. But this isn't about mental illness. This isn't about treating people who have mental health conditions. This is about supporting people to deal with a range of conditions such as stress and anxiety. It may also be to support people who are recovering from mental illness, but it's not trying to set up in competition to the Partnership Trust.
Okay, thank you. Can I just give you an example? example of the situation that is kind of involved with it, something personal. I was with a young person who went to see somebody who'd had this mental health first aid training.
Yes.
And was told that this young person needs to stop using social media and to come off the internet because that's causing issues. And then at the end, it was here's a range of online resources for you to go and sort yourself out. And I just thought I wasn't, and I'm not entirely happy with the resources. Nothing replaces face-to-face counselling and.
Well, that's not quite true. I'm sorry to have to take issue. I mean, all the training that I put up was for over 16. But I think there may be situations where it applies. I don't know the specific case. But if you look at cognitive behavioural therapy, or it's also called IAPT, which is a service freely available to thousands of people across the county, all the evidence shows that the online support available through CBT is equally effective as face-to-face. Now that may not, that's the generality of the population approach. That may not apply to an individual person and their preference or their history, but in general, online can be, depending on the situation, equally effective.
Thank you. At our last health OSP, we were informed that in this area only 33% of IAPT users completed their 6-week course. So I'm not as confident as you that it's effective.
Well, IAPT is face-to-face.
Telephone service,
But most of it is face-to-face.
right, not in my experience. Okay, thank you. Councillor Margaret.
Thank you, Chair, and thank you for your presentation. If I start at the end, if that's okay, Chair, this isn't necessarily a question, but the end slide did show a consultation, and I am aware that I'm not sure when this committee is next due to meet, but I would like to propose that, in particular to Local Health Watch, that we support the continuation of the current service, because we have had the Chief Executive present to this committee, and I feel that they're doing a fantastic job with very limited resources. So I'd be concerned if that service was allocated to somebody else, especially outside of the area. But I just wanted to pick up where we ended. In relation to your beginning presentation, first of all, I've got some concerns about the methodology that's used. So, for example, while we are comparing South Warwickshire and North Warwickshire, and there's a gap of under 10 years there, potentially, because with the greatest respect, if I get to 70 years old, and who knows, but if I get to 70 years old, I'd be quite happy, and naturally, people when they get to 70 plus years old tend to die. So statistically speaking, if you look at South Warwickshire and Nuneaton and Bedworth, actually, potentially, we've got people in this borough dying in their 50s or under 50s. And I just feel that your figures potentially don't reflect fully the concerning situation that, from other statistics I've seen, possibly present. So I just wondered whether you had considered looking at, and you may not do that today, but whether you've considered looking at the disparity between the age ranges of people who are passing away within Nuneaton and Bedworth compared to the age ranges within South Warwickshire. So because potentially you could get a whole series of people who are 70, but then you could get a small number of people who are in their 60s or 20s even, and that would create one figure, and then you would get, does that make sense? So
yes, I understand the point you're making, but the life expectancy figures which I put up are life expectancy at birth. So that's the expectation of life for a newborn today. So it takes account of the, as you're suggesting, an increased death rate in the 50s or 60s. So it takes account of those issues.
I think what I'm trying to say is I just wondered, and it may not be for today, but I'd be finding figures useful to know how many people by age are dying within our borough, because my experience, and I don't know everybody, but I know quite a lot of people, and I'm not just on about my own family experience, but I know a lot of people in the borough, especially men, where they possibly pass away in their 50s, whereas some people are older, into their late 70s, often women, from my experience. And so when we're looking at those figures, I want to understand when people are dying, and then we can understand why they're dying and what we can do about it, because you did pick up on that the figures have changed, but there wasn't much narrative around what the cause for that change is.
Well, okay.
So the next question was, I wonder whether you could unpack that narrative.
Okay, well, I think the slide, the following on slide, which showed deaths, preventable deaths. Preventable deaths, by definition, are deaths under 75 years of age. So that's, while it doesn't break them down into specific ages, those numbers relate to people who have died at a younger age, in their 40s, 50s and 60s, from the main causes of death. The main causes of death, accounting for about 2/3 of all deaths across the country, and it applies equally here, are cancer and cardiovascular disease.
So what
Most
is it?
people die from heart disease, stroke or various cancers. And those figures, the 300 and the 170, represent deaths of people at younger ages.
So we reduced the mortality rate, or not rate, we reduced the mortality figure, or the gap. There was a period where that was reduced.
Yes.
And obviously later on it's increased marginally, but nevertheless it's increased. Do we know what we were doing to reduce that gap? And can we do more of it, really? That's the question I'm asking.
Yes, we do. And it's a range of things which I touched on, which is good diet, physical activity, and stop smoking is probably the biggest issue for this part of the county, because we still have about 1/4 of people, adult population, smoking. And that is probably the single biggest thing if we could do. If we could reduce that to the level in Warwick, for example, where about 12% of the adult population smoke.
So the final question, which all of that led to, is in relation to your budgetary constraints and how you design policy. So first of all, I wonder whether patients or service users were involved in developing the services you provide, and it's actually designed by them. Second of all is in relation to budgets, because obviously if the gap has reduced and so people are living longer, obviously money's been spent on that, and I just wonder, now it's increasing and the trend is that it's increasing, may have only increased marginally now, but going forward, obviously if the trend is for it to increase, it's going to increase. So I wondered whether A, you need more money, and B, what you need that money to be spent on, because clearly we're going on a trend, we're going backwards almost. That's what it feels like.
Okay, well, as with all of the services across, I'm sure the same for Nuneaton and Bedworth, and the same for the County Council, service users, the public, partners and stakeholders are involved in the design and development of all our services. In terms of which services we provide, many of those are decided by regulation, government regulation. So, for example, we have to provide some drug and alcohol treatment services. That's decided, and that's a condition of the grant. In terms of money, I mean, I don't want to get too much into money. We could always do with more money, and we have very little money. The public health budget over the 5 years and ending in 2019 will have reduced by about 40%. Now that is a significant cut on the budget and limits our ability to provide the range or depth of services we would like. So of course I would love more money, but I don't see how that's going to happen easily in the short term.
Thank you. It's good to be on the Health Committee. I was very supportive of it being set up and wasn't on it last year. And it's good to have this overview of all the various different aspects of health. One of the key things I follow is statistics. So these graphs are marvellous. It'd be great to have a good look at the colour versions, because it really brings out a lot of the inequalities and challenges we face. And particularly on page 3, where it talks about changes over time on this one, if you have the colour version, you can see the early year deaths and things like that plateauing rather than improving like the rest of the country. So yeah, they are really good graphs, and if you zoom in on them on colour, they really show how we're failing to improve like we were. Going back to one of Sam's points, there's actually some really good data on the population comes out by year. It actually says how many people each age group actually die. Obviously the births are always in year 0, but you can see the population problems we have. And a lot of it is also then tied in with the population summary, which you've got that nice graph on page 2 showing the bulges in population. And we have a massive population that were born post-war. You know, if you look at the graph, 65 to 69-year-olds are really a dominant peak in the population. And then going down to the people born in the 60s like myself, who now only have about 3 years of healthy life left. So it really is important we actually look at these stats and start designing our health for the problems we have in the borough. Smoking, absolute killer, and obviously one of the things we have had good wins on has been smoking, but we also have far too much illegal tobacco sold and issues like that in the borough, which is a health issue as well as a crime and a revenue issue. So I hope we actually do some joint at working on the tobacco side. Air quality obviously then adds to all the other problems, and I was almost thinking you weren't going to cover air quality because it was right at the end of your presentation. But the borough really does have a serious problem, and the people who are overweight and smoke and all the other factors, air quality won't necessarily be the entire blame for them dying early, but will not help if we've got all the other health issues. And we're not doing enough about health quality here, health here. We're not tackling it as a problem. It is really something that I think we should actually have a campaign on to actually push it higher on the agenda. One of the other issues is being under GP, because the austerity is actually driving down health budgets. You've got this, Wendy, and we urgently need to be properly funded and supplied with GPs, because lack of GPs means that things are getting picked up later, and we're having less early interventions and less effective interventions. What are we doing about the lack of GPs as far as NHS Warwickshire and your things, your lobbying from the county councils to actually get that sorted?
Well, I wish there was someone here, because the responsibility for commissioning GP services rests with the CCG. And while we work with general practitioners and I provide a range of services, my department, to general practitioners, I have no direct involvement. Having said that, the Health and Wellbeing Board and the Health Scrutiny Committee at the County Council have raised this a number of times with the CCGs, and the 3 CCGs have come together and they're currently writing a primary care development plan, which covers and begins to tackle the issues around the shortage of general practitioners, which is more acute in the north of the county than the rest of the county, but also other primary care staff such as practice nurses and other practitioners. So there is work going on. It's work jointly with the University of Warwick and Coventry, who are the two main training facilities. There are a number of ideas, and for example, the use of pharmacists in general practice, which may free up GPs. The development of what's called a physician associate, which is very much an American model where you train people, but they're not a fully trained doctor, but they can do a range of medical tasks. And Warwick University has begun training physician associates. So there are a number of things, but it's a national problem and there's no easy answer. And in fact it could get a lot worse, because there are significant, as with the population stats you pointed out, the majority of GPs are in the older age group and coming up to retirement, and we're struggling to get new doctors to take up general practice.
Well, can I just finish on that point? Because it'd be useful in these charts of health profiles of all the problems we've got and all the reds to have a column in here of how many GPs per 100,000 of population and things like that, to actually highlight not only we've got the biggest reds and oranges, that actually we've got the worst resources.
Okay. That isn't routinely available, but I could, for the committee, I will talk to NHS England and see whether we can get a breakdown. I think it'll probably be by CCG rather than district or borough.
Any other member? Just got a couple of things myself. You've mentioned about the children and self-harm and how worrying it is.
Yes.
In terms of your priorities,
Sorry?
where is that going to sit in terms of your priorities? Because
Well,
in your priorities it's not really mentioned.
Well, it's with there is a focus on mental well-being, and we are working not just with the CCGs, but particularly with the Partnership Trust around this. And it's a long story, but the child and adolescent mental health services are being re-tendered at the moment. There is an announcement due any day now, actually, as to who will be the new service provider. And the specification, which was published by the 3 CCGs and the County Council, very much puts an emphasis on prevention, working with young people, and begins to move back to what we used to have, which was much more close working with teachers and with schools who recognise problems like bullying, which of course has moved on to cyberbullying, and all the different problems that happen as, you know, that can occur as we grow up, particularly into our teenage years. The majority of severe mental illness that we experience as adults for the most severe conditions begins when we're teenagers. That doesn't mean we can't get depressed or anxious or a range of other conditions at any age, but for the most severe mental illness. So childhood and those teenage years are key to mental well-being, and I'm hopeful that the new service, which should be starting in the next few months or early next year, will have an effect on some of these figures that I presented, particularly around deliberate self-harm. I could talk about that all evening. The House of Commons Select Committee published a report last year about deliberate self-harm, and it's very difficult to pinpoint an exact cause, but they pointed to, and it's something you referred to, use of the internet, and particularly the bad side. I mean, the internet is a wonderful thing, but you know, for young people and how we preserve their safety and their usage, particularly in, you know, if they're on their own in their bedrooms, you know, a lot of people still haven't thought through the ill effects.
Thank you. you, Chair. I think you highlighted a really important point there, in that we don't fully understand the causes of mental health illness. There are triggers and there are things that make it worse. But my concern is that if we don't fully understand the causes, but the focus is on preventing mental health illness, actually we're not going to do a very good job. And my concern is at the other end, in relation to young people, in particular children, who have got mental health conditions or are self-harming. And I think it's important to define those broadly under mental health. I'm not comfortable with separating them out. That might be a policy approach, but for me, broadly speaking, it's all mental health. And so when we're looking at young people and children, I just wonder whether, first of all, we could have a more focused report come back to this committee in future when this new service is in place, but also to understand why then, if we don't understand the cause, we're focusing on prevention, while there are preventative measures we need to take. Actually, where are we with treatment? So if a young person today is self-harming, what service is in place for them, this evening or tomorrow morning to treat them? I just wonder.
Right. I'm not making a distinction between, you said mental health and mental well-being. It's mental illness and mental well-being. We all have an issue of well-being, but I didn't want to focus just on mental illness, and particularly severe enduring mental illness, because there is a lot as a community we can do. I don't agree with you that we don't know the causes. I'm not saying we know the cause of everything, but we do have very strong evidence now around, for example, genetic causes relating to conditions like schizophrenia and some of the more severe illnesses. In terms of the issues of mental well-being and into mental illness, there is a lot of accumulating evidence about early years, particularly around attachment theory and what happens with parenting and the impact that has on us as we socialise, which isn't just about us and the way we behave, it's actually about the architecture of our brain. So if you have a child in a loving environment who is stimulated by sight, sound, smell, all of the things that normally happen, that child begins to grow lots of neural connections in their brain. If you then take a child who is in a situation where they've been, it doesn't even have to be abuse, but they're not stimulated, they're left on their own, they will not develop those connections. So, I think what you say is interesting, but I think we do have a lot of
I think
accumulated
just to
evidence.
clarify.
And then, therefore, we know that how we can begin to prevent a lot of the well-being issues that arise.
Importantly, just to clarify for the committee, and
With the chair next time, please.
thank you, Chair. Importantly, to just respond and clarify, I understood, and I may have misheard then, that Parliament. I thought Parliament had said we don't fully understand the causes, but
Of deliberate self-harm, of
Okay.
deliberate self-harm, the rise in deliberate self-harm.
But in relation, and I'm sure these issues are more complex, because I'm sure you're not saying, and it's important to clarify that the parents aren't there. There may be some relationship between parents and people and young people or children with mental health conditions or self-harm, but it isn't necessarily always that clear cut. But you haven't really answered the question in relation to. We've got to focus on prevention, but where are we with treatment? So what are the timescales now that young people can expect a service? See, we've spoken about the white wall, or the wall.
The white wall.
Yeah, online. But obviously if a young person goes to that, and really they need, they need somebody face to face, how soon will they get to see somebody face to face?
Well, the current waiting times for an initial assessment are between 4 to 6 weeks. If it's an acute or urgent situation, obviously that's totally different. So, for example, if you were admitted with self-harm and you're brought into A&E and admitted to hospital, you will be seen by a psychiatric nurse and a psychiatrist either the evening you're admitted, if it's an evening, or the next day.
So do we know how many people who have been referred, so are on the waiting list, but not necessarily going to be seen for 4 to 6 weeks, how many of those people then self-harm within that waiting period?
I would have to look. I mean, I haven't come along.
I
don't commission this service, but I can find out the figures for you. I mean, the numbers wouldn't be huge, because deliberate self-harm is one manifestation of the issue in young people. There are a whole range of other issues, and the numbers that are referred to the child and adolescent mental health services are significant and are growing year on year. But if you need figures, I can provide the committee with figures.
Councillor Ellis.
Thank you, Chair. I am distressed to hear you bringing up attachment disorder. I just wonder if you and the committee are aware of the number of very loving, very involved and professional, fantastic parents who are being told that their child's difficulties are attachment disorder. But related to that, my question is that you've just said that CAMS is being re-tendered. Can you tell me what that means and who now runs the service? Is it not the NHS?
I didn't say that. I said CAMS has just been re-tendered. We're waiting for an announcement any day as to who the new provider will be. So I don't know. It hasn't been announced.
Who currently runs this?
Sorry?
Who
Currently,
runs
the service has always been run in this area by the Partnership Trust, Coventry and Warwickshire Partnership Trust. I was talking about the studies looking at the development of the infant brain, the childhood brain. I wasn't specifically talking about attachment theory, though that is one part of the overall issue. And, there is, I mean, it's too big a topic, and I'm not saying either one thing or another. I'm simply talking about the accumulating evidence about the importance of the early years in a child's development. And that's something that we always knew, and we've tended perhaps not to spend as much time on. And that ranges from simple things like reading to more complex things like neural development. That's all I've been saying.
Councillor Pompey.
Thank you, Chair. I would just like to mention that last year the committee had a substantial input from CAMS at a number of our meetings, basically covering all the questions that have just been asked regarding referral, waiting times, how the CAMS work with families, work with schools and so on. It may be that perhaps sometime later in the year that we ask them again, but all the issues that have just been raised were covered some months ago.
Is actually on our way to come again. But it'll obviously be whoever the new person is. Councillor Pompey.
Yeah, I was just going to say, it's actually quite a good suicide strategy being done by the County Council. As there's lots of other things going on, and I think today was very much an overview of everything that what Warwickshire does and the joint reviews and the sort of top level stats. So it is useful to then go into more detail, and particularly maybe get someone who's looking at the suicide strand of work to maybe come and, rather than you dig out statistics, actually, we have someone who's more specialist in that area come and talk to us, because there is a lot of really sad cases, very small in number effectively, but very sad, and it's trying to get them picked up. I know the railway police and that have done a lot of work at the railway station and things trying to, but there's so many places where things need to be picked up. I think it's probably better to have a special session on it rather than be too much at the top level.
Can I comment on that? I mean, it's somebody in my department who's leading on the suicide prevention strategy. It doesn't come up as a raid on the health summary for Nuneaton and Bedworth, but actually at a county level we are red. We are an outlier because of the relatively high numbers. We're still talking about small numbers overall, but for suicide across the county. And so we've been doing a lot of work to develop a prevention strategy, which is now was signed off earlier this year by the Health and Wellbeing Board, and which we're now beginning to roll out across the county. So I'd be very happy to get my staff to come along and do whatever, whether it's a briefing or presentation or report, whatever you like.
Can I just mention one quick line? The rate's actually quite high at University of Warwick and Warwick, because it's actually when people go from here to college and they're young chaps particularly when it happens, but obviously it is all part of their life's journey.
Any other member? Can I just mention the health store?
Sorry?
Can I mention the health store, which
Yes.
is in your presentation now? Last year when it nearly closed and
Yep.
we all had to root round for £5,000 each to put it
Yep.
together. Now obviously it's in the domain of public health, so can I ask what the plans are in terms of the health store?
Sorry, you said it's in the domain of public health?
Well, it sits with yourself, doesn't it?
Well, no, it's a partnership issue. We contributed a small amount, as well as the other partners, on behalf of the County Council. Decided to put money in. The sexual health services, which are provided as part of the health store, are actually commissioned by public health. So we're already putting resource in. So I think in the context of particularly the teenage pregnancy rate, it is very important that the service continues. The various partners, I'm hoping that they will all get together relatively soon to look at how we make this service viable. The additional funding that was found was for 1 year only. So we still have a task to find a way to make this a viable service for the future. But it's not just for Nuneaton, there's also the issue of North Warwickshire, because they also have a significant challenge around sexual health and teenage pregnancy. So I can't give you an answer, but in terms of a solution yet, but that's something that needs to happen over the next 2 months.
We can ask for application in September.
Okay.
Any other member? No? Thank you very much for your time.
Pleasure.
I do have concerns about all the reps we've got now compared to all the rest of the districts. What you would expect me to say about them. You're very welcome to stay for the hospice provision if you wish, or you can sneak away.
I'd go.
I know the story.
Oh,
Thank you very much.
thank you, John. Moving on to the hospital.
Okay. Would you like me to
Yeah.
stay here? Am I right to stay
Yeah,
here?
that's fine.
Thank you very much for an opportunity to come and speak to you. I understand that the primary reason that you would like to hear from me is in regards to the provision of end-of-life beds in Nuneaton, and obviously that for us includes the whole of the north of Warwickshire.
There is an awful lot of work going on at the moment across North Warwickshire, including Nuneaton, and I wanted to try and put that work in context for you because end-of-life beds is a key part of that, and I think it would be helpful for you to understand the whole and not just the one little bit. So you may be aware that sort of last autumn NHS England got out their sustainability and transformation plans, which really means that there's no more money, which we know, but we need to change things and we need to change it quickly, and we need to do that with innovation and lots of people doing everything for nothing. However, that's the cynical view that some people may take and you may have read about. Locally, I would say that we've been really privileged because it's actually brought an opportunity for many organisations like the one I work for, Mary Ann Evans, to work with other people that we probably wouldn't have been working with before. So we're seeing the advantages of that partnership and the integration. From the NHS England driver, they set up a design board and then local design groups, and I'm on the design group that covers North Warwickshire, of which obviously Nuneaton is part of. We were given key tasks, and one of the key priorities that the design group want to look at as an out-of-hospital collaborative is end-of-life care. So by December last year, we had written what I've shared with you, pre-papers, the end-of-life care pathway, which is really our aspired vision for how we'd like to see things changed and improved for local people. Very clearly in that document you will see the provision of end-of-life beds, and I hope that gives you some reassurance that this is a very hot topic for us at the moment. I also would like to say that I'm very conscious that the subject of which I speak may be very sensitive to some, maybe all, of you that are sitting here, and I don't do my subject lightly, but I obviously have got limited time and I need to get through what's going on. Out of the end-of-life pathway, the Warwickshire North CCG have held 2 focused provider engagement groups, multiple providers around the table, and we've come out of that with 4 to 5 key work streams, one of which is end-of-life beds. Another is rapid response, a hospice at home service at night to try and help people be at home where they want to be. And we currently have no overnight district nursing service in the north of Warwickshire and Nuneaton. The services finish between 10 p.m. and in some areas 12 midnight. So the hospice and the local community nursing service are aiming by the end of September to have a very new service as a pilot where the district nurses and the hospice at home team will go out through the night to people who are in trouble and are dying. That may help them not go into hospital because they have some practical help coming to them in their home. End-of-life beds. The CCG are committed to trying to put some form of end-of-life bed concept in place by the end of this year. That's a really tall order for us providers with no additional resources. So we're not talking about a building customised at the moment, but we are talking of working with local partners such as George Eliot Hospital, local nursing homes, maybe where we could have some dedicated areas to support people with all of the hospice services contributing in those beds. That's very, very early stages, please. There is no commitment or signed contracts or anything. We are starting the conversations now, and we're beginning to look at who we may want to work with in order to make that a reality. As far as actual beds in the area, my understanding from the clinical commissioning group is that they know that that is something they have to commit to, and that hopefully within the next 3 to 5 years we'll see something very different in this area. We're going to a meeting only next week with the George Eliot Hospital to look at, is there anything in their campus that we could maybe customise as an area that the hospices across North Warwickshire, and I include Nuneaton in that, can work together to provide some form of inpatient facility. I have to stress that we must have the CCG on board with this, because I'm sure you appreciate as charities we don't 100% fundraise everything. We do have a percentage of money from the CCG, roughly 25 to 30% of our funding will come from the CCG, and that's a very important percentage to commit to having a bedded area. Beds are the most expensive part of providing end-of-life care, and I'm sure if my mountain colleagues were here they would back me up with that. I think what is important to note is that we are focusing initially on end-of-life beds, so that is for people where they haven't got highly complicated issues such as extreme pain or extreme psychological issues, because that's where Nuneaton Hospice are the experts with those sorts of beds, as well as St Giles, where people in the very north of this area will go, and Marie Curie, Solihull, where people in the west. I suspect that people in Nuneaton and Bedworth will tend to use the Nuneaton beds, which are Coventry and Warwick based. But I also acknowledge that that can be a heck of a journey for people and not a journey that people would want to make, which is why we are really, really passionate about trying to put some local provision in place. Lots of challenges in that. I want to echo some of the things Dr. Linnane was saying around the demographics in Nuneaton and Bedworth, and obviously as people, if they're unwell through life, they will have more complications in the end of their life, and therefore that makes our jobs harder too. So the healthier our population is, then the better we can be at the end of life for people and their quality of life at the end of their time. Funding, I don't need to labour, you understand the pressures on funding. But another key thing is mentioned by yourselves around the doctor situation. We have a real workforce issue ahead of us. Much of our workforce is heading for retirement, and the specialist skills that we need are simply not being generated through. The demand for people who are dying and people want to be at home. I also chair the National Association for Hospice at Home, hugely passionate about helping people to remain at home if that's their choice. We understand what we need to do to help people, and the key people that need support at home in order to enable them to remain are the family carers. And that's a massive agenda, and I did notice that Dr. Linnane referred to carers as well. That's another key work stream that we've got on our immediate horizon. But that isn't just about what the hospice is doing, that's about what anybody who touches the journey of somebody who is diagnosed as being at the end of their life has a responsibility to work towards. So there's lots of other things happening. I'm conscious that I've listed lots of things up there, but I know that the hot subject that you would like to maybe ask me questions around in particular is end-of-life beds. Is that okay?
Thank you, Chair, and thank you for coming today. I'm disappointed that Andrea's not here, and I think this committee does need to take up this issue with the CCG, because funding is critical, and I thank you for your candour. I raised this issue on a number of occasions with this committee because of my own personal experience. My father was terminally ill and passed away about a year and a half ago. And end-of-life care doesn't just start in those few days when somebody's passing away. It actually starts long before. And in my case, having to go to a hospital and sit there when a doctor tells your own dad that he's going to die and he doesn't really get it, is incredibly difficult. But what I do want to say is the work the hospice do, and the carers at the hospice and the staff at the hospice, and also in the NHS do, is fantastic. And so anything I say that's critical actually needs to also take into account resourcing and the passion and love and care that they have. And my dad loved the hospice. I think there are a number of issues that I wanted to highlight. First of all, is in his final moments, as it were, and not just his, but my neighbours and other residents have contacted me. It was amazing, really. It was sort of almost as if I I went into something on my own and ended up with a sort of community that I'd become part of about all these people who'd lost people. And I think one of the issues is in relation to not having the beds here in Nuneaton and Bedworth, because travel is really hard. To get to Warwick, it takes hours if you're on public transport. And so for me, 3 to 5 years is not soon enough. And I think we need to make a big campaign of that and try and lobby for some extra funding. I don't know how much it will cost and all of these, but I think we need to do work around what is possible and how can we make it happen. In relation to my own experience, you know, there weren't any beds available anyway at the other side of the county because there were lots of people using them at the other side of the county. And so you've got the issue in relation to beds and that provision, and I think we need to look at that more and try and find the money, or at least lobby for the money. I think there's another issue, and I raise this sort of respectfully because I understand it is good practice across the sector now, but obviously hospice care within this borough now has been, I don't want to say reduced, but changed, transformed, which is a word they use in health for reduced. Effectively now, my understanding is that hospice care, it might not be the case now, but previously you get referred to a hospice. So let's say you're going to pass away, and you just don't know when, but you only get 12 weeks. And although it can be extended, because of your capacity issues, you have to limit the provision you can provide. So there are people who might be going through the process over and over again. Yes, you extend for some people, I'm sure, in certain cases, but they may not display those symptoms. There are people who are walking around who are terminally ill or being treated for end of life, but they might be fine. They might then be discharged, and then they've got to go back to the GP and be re-referred, etc. And I think we need to look at that. And finally is looking at the issue of grief, and generally people coming to terms with that whole process of bereavement, but before somebody dies. And I know there's a lot of emphasis in doing that, but I think it's really important because people want to pretend that somebody's not going to die, and I'm not just on about me, but it was just afterwards that I did a lot of reading and a lot of watching YouTube videos. I never did any of that before. And I think it's really important because that will then trigger the conversations about what people want. And in my own case, you know, my dad loved the hospice were lovely, but equally, he passed away in a hospital bed without a window. There was another patient opposite him who had Alzheimer's and was screaming and running around. He was given all the end-of-life drugs that he said he didn't want. And that was, you know, when I had gone home after 36 hours. But he had family with him when he passed away, although I and my brother and sister weren't there, and possibly that's a good thing because it's the worst thing I ever did go and see him. But I understand now more than ever that people, not only this borough but everywhere, but the people of this borough, it's a real journey that they're on, and it's something we don't really think about. I mean, it's not something I ever thought about, and I want us to support you. So it's not about being critical. I've not asked for this agenda item to complain about budget cuts and all of that, although I'm sure there'll be other opportunities to do that. I wanted to highlight that there is a need, and I think we all know about that need, and I just wanted to get it onto the agenda. So,
Can I respond to a couple of things? Just to, I think we do need to prepare that even if we get, not even, when we get beds in Nuneaton and in North Warwickshire, we simply will never have enough. And therefore, we must be not just focusing on beds, we must be doing all of the other work that I've mapped behind you and we've mapped in the pathway. We cannot just rely on beds, sadly, with the changing demographics and just everything. So we've got a real lot of work here because we've got to change the culture and the approach. Everything that we do in the hospice movement is with utmost passion, dedication. It's a tough job, but we do it because we genuinely care and we genuinely want to help people, and I thank you for acknowledging that. But we need to cascade that approach to when you are in a hospital bed, and that is the place that maybe you want to be. Some people do want to be there, they feel safer there. Or maybe you're in a nursing home, or a residential home, or even at home. We must be getting it right wherever people are. And a lot of what we've set out in the pathway and the work streams that we've got going on now are trying to start to really address those issues. There's the compassionate communities, which is coming through public health, working with the providers again. That's around getting people talking about death and dying and helping them. And we run the annual Dying Matters awareness, and we get a lot of criticism for using the word dying. But if we hide away from using the word dying and good death, then we're just following everything else that people are complaining about, that we aren't talking about death and dying with them. The timing of those conversations is really difficult, because we health professionals would love to have, in hospice health care, we would love to be having those free and easy conversations with everybody whenever we want to. But we can't do that, because we have to go at the pace of those individuals that have got this life-limiting illness and their families. And sometimes their families just do not want to have those conversations and do not want to engage. And we can see this person changing, but we cannot force the conversation. We can break their trust by doing that, and that would be very damaging. So I mentioned about beds and not having enough, and why we've got to do all the other work as well. You talked about a 12-week programme, which at our day hospice we run now a 16-week programme, which the reason why we do that is that we've tried to extend, and another point that you made, we've tried to extend the opportunity for more people to come into the day hospice. Previously, people were coming without ever being discharged, which meant that there was only a set number of people could access the hospice. So just off the top of my head, 2 years ago, the day hospice only had 22 new patients come through the doors. At the end of this year, we end our year on the 31st of March, we had 105 new patients through the doors. So that means however many more percentage-wise, a lot more families having that opportunity to even get some support is better than no access or no support at all. And yes, we do, you're quite right, extend the clinical programmes where there is a need. But we're also trying to enable people to live with dying. So to make them dependent on coming to us every week can for some people be a very unhealthy way to be living with their dying. So we're trying to give them skills and approaches that help them cope with what they're dealing with, but also supporting them at the same time. And we are very much trying to listen to what matters to them. Grief, the hospice in Mary Ann, we have a very good bereavement service, and we are beginning to extend our pre-bereavement service. It's a really low cost but high quality model, and that's because 70 people in that service are volunteers. There are only 3 paid staff, not all of them, they're not all full-time, they're all part-time. So we are a very economic model. The other thing that we do, we've begun to work with children, so that children that are struggling with either the death of a loved one, a sibling, a mum, a dad, a granddad, even if their loved ones have not come through the Mary Ann Evans Hospice care, they can still have bereavement support, and that is quite unique in the UK. There's a lot of things that I heard that the Nuneaton are in the red. Actually, take some congratulations there, because here you've got a hospice actually that does provide bereavement services, whoever they are. Okay. And the last thing, no, I think that's it. I think I've covered everything, and more questions by all means.
Firstly, apologies for being late. I've been on a school trip in the Peak District, but for some odd reason I've written 6 o'clock in my diary, so I thought I was making quite good time. Clearly I wasn't. It's interesting, so you actually just used the phrase that I just wanted a little bit of clarification on. In the report on page 48, where you've listed some potential performance indicators, one of them is listed there as being achieving a good death, which is a bit of an oxymoron if ever I heard it. I just wondered if you could clarify what a good death actually involves?
There is no written standard or statement about what a good death is that you could hold up and measure. But for me and for the ethos of the organisation and many hospices that I work for, a good death is about getting it right for that person and their family. So it has to be very personalised and individualised. The general public would say a good death is being with the people that matter to them, that they're out of pain and they're as comfortable as possible. A lot of people say that they want to die at home, and that would be a good death for them. But we know in this area that about 50% of people are actually dying in the George Eliot Hospital. And the numbers here, I think your population is just under 190,000 across the whole of North Warwickshire, which means that anticipated deaths of that expected deaths is around 1%, so 1,900 people. And over 800 of those people are dying in the George Eliot Hospital. Now, some of them may want to be there, some of them may want to be at home, and that would be a good death for them. But their carers may not be able to cope with what is needed. And I would like to emphasise here that whilst the person who is dying may say they want to be at home, unless their family are able to help and support them, their chances of staying at home are very, very small. And the reason being that you do not get 24-hour non-stop care services coming into the home environment. And it would be incredibly silly of me to ever propose that that would be the case, knowing all of the challenges that we currently and will continue to face going into the future. So we have to do more to prepare those families that are willing. We have to do more to support those people with their choices wherever we can. So a good death statement I can't give you, as in NHS England say this is a good death, but I can give you snippets of what I know that means to people from what I have learned and read and my knowledge and experience over the years that I've been involved in this line of work. Does that answer you enough?
Yeah, I imagine everyone sitting around this table probably has some sort of experience of a family member, a friend being at end of life. And I know when it was with my granddad, we actually weren't really even given the choice of it being at home or somewhere else, because by the time we found out it was end of life, we were talking days rather than weeks or months. So actually for us, there was never really a decision to be made, because in that time frame we couldn't have made the necessary preparations anyway. But yeah, I was just curious as to what that phrase sort of entailed, because it doesn't come across as being blunt as such, but it's quite a broad term for something that is so complex.
And I appreciate that I am completely and utterly immersed in my passion and my subject, and I will use language that is very common across my profession and environment, but not to yourselves. I do want to just have the opportunity to say though that I've only been in this area for 2 years. I've decades of experience of this field, but in this area only 2 years. And one of the things that's really impressed me, another good thing here, is the service that Mary Ann Evans Hospice offers in conjunction with George Eliot. And where someone is identified as dying and wanting to be at home, our average time of getting them from that decision to home is under 6 hours. And that is rare that we cannot do that. And I know that for a fact because every time that doesn't happen, they're meant to come and talk to me. So we have got some really good things happening, but the other issue is that sometimes the hospital staff can't identify that people are dying. And therefore they're not given those opportunities to be considered. That's another thing that we've got in our wish list of things that we've got to start working on. And that is ensuring that people know how to recognise dying as much as we possibly can. It can be challenging at times.
Just a couple of quickies. Really striking the 70 volunteers and 1.5 full-time staff. It's trying to get funding And how do you get, if you get people out of the hospital into the hospice care at home or hospice care in bed, how do you get the money to follow them? Because you're obviously then saving the NHS money, and your service might cost X per day you're looking after them, but it surely must be saving Y, and Y is a lot bigger than X.
And I have the assurance of the clinical commissioning group that any pilot that we are doing, for example, the rapid response at night, that as long as we can demonstrate an impact in the reduction of emergency admissions of dying people to the local hospital, the money will follow. It won't be fully funded, it will never be fully funded, but the charity would never want to be fully funded because that means we lose the authority to shape our services in the way that we know our local people would want them.
And just a second point, there's quite a few acronyms in your thing. Yeah.
Sorry.
Yeah, the only one I couldn't find anywhere was the MDT, which is...
That's a multidisciplinary team.
Okay, I've got all the other ones.
I'm so sorry.
And we really do support the hospice all around the borough. I mean, we supported you by eating ice cream at your garden party a couple of weeks ago.
Thank you very much. I was there serving in the volunteer side.
Yeah, the hospice has a lot of support from the town, and I know quite a few of the mayor's charities over the years and other charity things have raised for it as well.
We currently have that for the lymphedema service. It's the mayor's appeal at the moment, and we are immensely grateful. We cannot do it without that. We really can't. Thank you.
Just because I felt it was really important to have the conversation. And I think the conversation has actually possibly moved us beyond beds, because there are wider issues that you've raised. And I would be interested in how we could, as a local authority, support you in your work more, because we already do, but whether it's, I've forgotten the name now, and I don't want to call it Dying Week, but Dying Matters Week, you know, whether we can support that in some way. But obviously then that triggers questions around, will it, emotionally, how do we support people if we're raising awareness? So it's, but, you know, there are other things that I would like us to support you in, and obviously I hope that we can raise with the CCG a number of these issues around funding. And although you did say, you know, you wouldn't ever want to be fully funded, I'm sure you would, but you want the participation too, and all NHS services should have patient participation. But you are overstretched in my understanding, and you do a fantastic job. And I would like us, if we could as a committee, to note that and to thank all the staff and volunteers of the local hospice and to just pass that back to them. But
Can I get a copy of
yes, and I think that would be really good. But equally, just to look at action points, and whether that's today or whether we can email the chair, but I would like to see us as a local authority look at how we can support your work and also push forward some of these ideas, because you set out a vision, and I love the vision, but we need to tie it down and make sure there are action points, potentially money and dates, but I can't promise that, but that's what I'd like to see.
I think for the first time since I've been here, I really feel confident that we are going to make some significant changes. And I may lose a lot of sleep and a lot of hair in the process, but I'm very committed to seeing it through.
Can I suggest that you said about the pilot scheme starting in September, so perhaps the pilot scheme could come back to this committee in March just to see how it's gone, any teething problems, and that, you know, we could support with funding.
Thank you, Chair.
You've mentioned about the clinical commissioning group supporting you if you have evidence of a nurse going out as an emergency at night. Is there going to be any support from the CCG to support another nurse who will be going out on the day shift to replace the nurse who's gone out at night?
I can't answer fully.
Because it's actually taking away from the client or customer base or patient base during the day.
I'm not in charge of the district nursing service, obviously, but I am working very closely with their managers at the moment in this project. And I'm not sure how they're going to resource the service, but I haven't been given the impression so far that they're going to rob Peter to pay Paul. I think it wouldn't be unfair of me to say that there is an incredible stretch on district nursing services across the country, let alone just here. but there is some confidence that I've picked up from them, that they've done a lot of work, and I'm going to use more health terms, around people who have a catheter into their bladder, which not everybody needs one, but a lot of people will need one. And when these catheters get blocked, they cause huge discomfort and ultimately can lead to somebody going into hospital. And they've done a lot of changes in their work that means that that is much less of a problem, and they've sort of gained a lot of, not a lot, they have gained some nursing hours back from that. And I think they're wanting to channel that into new initiatives such as the rapid response. But not everybody wants to work at night, and we won't be sending a nurse on their own. There will be a trained nurse from the South Warwickshire Foundation Trust who provide community nursing service. There will be a trained healthcare assistant, a specialised nurse, not a trained nurse from the hospice. They will go together, because obviously working at night is a big risk. Does that answer you?
No other member? No, thank you very much for...
Thank you. I'll just go and get that on
That's all right, no problem.
Thank you very
Thank
much.
you very much.
Thank you for the opportunity. I've enjoyed it.
And now to item 9, school development.
Thank you, Chair. Good evening. Tonight I just wanted to provide a brief overview of the report that you've passed in front of you, and that's just to give you a summary of some of the work that the sports development team have done over the last 12 months. I wasn't going to go through every page, but unfortunately I've noticed that the first few pages are not in order, so I'll refer to the page numbers just so I can provide a few more highlights. As Dr. Linan mentioned, we do work closely with a number of partners, and the Fit for Future one is one that we've worked with Rugby Borough Council ourselves and secured a full-time post to be placed in the Nuneaton Bedworth supporting families. And it was a pleasure that John sort of spotted that and some of the excellent work that's been going on. So I just wanted to highlight that. On page 59 with the healthy people, I'm also very keen on topics that have been mentioned before about volunteers. We've got a vibrant walking fraternity in the borough under our Walking for Life programme, and we currently have 23 volunteers supporting us delivering that. They currently do about 110 hours a week for us supporting those walks. There are an ageing group of people that support us on those walks, and we're forever trying to encourage and train new people. But without those volunteers, we would not be able to have such a positive walking group that we have got. And I think just noting that, we worked very closely with Warwickshire County Council 2-3 weeks ago on their volunteer evening, where volunteers were celebrated and awarded for their dedicated hours, and that's something we'd like to do more of, because I think we perhaps at times don't support volunteers as much as we can do going forward. Sorry, 2.3 there was around the Fitter Future and the Public Health Partnership. We've got a further 12 months delivery in specifically in Nuneaton and Bedworth with Joanne that works in our team, and she delivers work around the 5 to 13 age group, working with, it's a family member, parents and their child around Fitter Futures, which is all around change makers. So it is around portion control, it is around diet, nutrition, it is around physical activity and exercise, and it's around a 12-week programme. And we've had some real positive results working with schools with that. And John Linan, as you heard earlier, is looking for that project to be further enhanced and developed because of the outcomes being achieved. On page 61, on 2.6, I've talked around employee health checks. As a borough council and a local employee, we have a number of people that work throughout the whole of the council, and 76 employees we worked with over the last 12 months. Some of those significantly have made some health big impacts and changes, whether that be weight loss, whether that be medication reduction, whether that changing their lifestyle, and that's also impacted on their local family. It does detail in the report Appendix A and Appendix B, which gives some further stats. I will circulate those after tonight's meeting because there's some real positive outcomes. Not everybody wants to be named, and quite a number of the delivery that we do, people want to be anonymous. So there's some nice, clear evidence and stats in there, but the names are obviously just made up, etc. But we had some very big impacts down at the council depot in terms of health, well-being, food control, enlightening some drivers around a cooked breakfast every morning, followed by a drink later on in the day around moderation, and some impact there with some, at least one gentleman, like losing 7.5 stone over 12 months, which is a real big impact, and it's changed his family life, and his wider family as well. That's made some big changes, so some real positive impacts. Just moving on to page 64, just a real update in terms of Bedworth Cricket Club. I know quite a bit of press has gone on right now, and there's a couple of pictures in terms of the work that has started to progress at the Miners Welfare Park, as a model there in terms of working with a club, substantial amounts of external funding, working with a club that the Borough Council would not be able to get if it was working on its own, but working with a partner and a local organisation, the sports club, has meant, £250,000 plus has been brought in from external funding, which is significant, and the work's progress. We are looking to finalise the new change rooms for football, cricket, miners' welfare delivery in September, with some further works that the club will be delivering later on in the year. But a total project cost of £421,000 is not insignificant with the amount of funds that's been raised externally. Just quickly moving on to page 69, 4.10. We working with the Nuneaton Harriers and some further external funding. The Nuneaton Harriers developed a foot golf course which commenced late last summer and is currently on the old pitch and putt course at the Pingles Leisure Centre. There has been, over the last 2 weeks, there's been a requirement to do some remedial works in terms of grounds maintenance, but I just wanted to update on some numbers that we've had from the day it opened to today. We've had 273 adults and 527 juniors. That may not sound a lot, but that's the people that have booked and paid to use the site. I can imagine that there are many others that have just taken their own equipment, their own football, and just played their own game on that foot golf. So it's essentially golf but using football. That's not to say it did need some work, and it was pointed out to the sports development team and the parks team following a member involvement that there was some grounds maintenance works to be undertaken on there. It had got a little overgrown for the summer, but those works have been undertaken now. So it really is just another facility in the Riversley Park, Pingles Leisure Park area. What I've also got is some further updates just around the team. The St Michael's Primary Academy in Bedworth had some building works on their school site to increase their school capacity, and because of that they were building on grass playing land. Several meetings were undertaken with myself, the head teacher, the head of PE and Sport England, and there was a small-sided artificial grass pitch developed on that Bedworth school site. That's subsequently now finished, and we're working with the school to get planning permission to put some floodlights in. That's another facility. It's not owned by the Borough Council, it's not managed by the Borough Council, but as part of that agreement and as part of their planning permission, they had to have community use. And I'm pleased to say that they are looking to see how they're working with two local large football teams, Bedworth Eagles and Bulkington, to essentially use that pitch as their home training pitch. During this weather, obviously training can happen anywhere, but come October there is a real shortfall of quality training provision for junior football and youth football, and it's something we want to try and encourage to keep young people involved in football. We're also looking to do some girls football on there from September and October as well, and develop that through Nicholas Chamberlain School. But that's another facility that we've got developed in the borough that we haven't had before and not obviously available for community use. As part of my team, I've got two part-time, only work 10 hours a week, youth contact team. They work out of hours Monday to Saturday, between the hours of 6 and 9 PM generally. And they're to support the Borough Council members of the public and also partners around antisocial behaviour and small fires. I really just wanted to point out that the storm report that we've had from the police last week through Rachel Jackson's team just shows that we've had a decrease in antisocial behaviour by -3% and deliberate small fires by -45%. I'm not for 1 minute crediting just those 2 employees, but they've certainly supported that over the last 12 months, and we've seen some positive reductions in those stats in those 2 areas. Still lots of work to do, but I think that's a team effort in terms of all those partners. I was asked earlier in the week, and also by the chair, just to feedback on 3G pitches and health concerns, because of some news articles about in Holland, third generation football pitches being ripped up, and also in Washington in America. The information I have found is, and I just really wanted to recap and provide members with an update. We have 6 artificial grass pitches in the borough. Then they're called 3G, and 1 sandfield, which is at Eton. So the pitch at Eton is sandfield, which is a sand layer to support hockey. The football third generation ones are a rubber crumb. So it's a tyre that is crushed and then is left on the surface to give a natural bounce for football. Predominantly football is a third generation pitch. I think late last year there were press articles detailing that in Holland they were investigating issues regarding carcinogenic in the surface in the rubber crumb, and some of the pitches were either being not played on and potentially being ripped up. I've contacted the Birmingham County FA and also the Football Foundation to seek their feedback on that. I'm pleased to say with the 6 pitches that we've got in the borough, all of those 6 pitches were done under a framework contractor. So the Football Foundation that supply any funding, they have to have gone through a rigorous specification to be one of their contractors. From my understanding, all the 6 pitches that we've got in the borough are through that framework contractors. So there's quite a specific specification that they have to deliver to. The other feedback I've had is that there is no health evidence that has been proven to date that third generation football pitches cause any issues around the health that was being classed by Holland and also in the States. And the feedback that I've got from the FA in their statement, which I can circulate, essentially says we've monitored numerous independent scientific studies on this issue, none of which have identified a risk to human health and environmental safety as a result of 3G pitches and rubber crumb. DEFRA is a lead agency on this matter and is currently contributing evidence to the EU-wide study. We'll continue to work with them to reinforce the forefront of research and therefore ensure the safety and well-being of people who use 3G pitches. In the Netherlands, new research released in December 2016 from the Dutch National Institute for Public Health and Environmental indicates that the health risk of playing sports on artificial grass with an infill of brominated rubber is virtually negligible. So I got that direct from the FA in terms of feedback on the pitches. What I do understand, and I'm just very mindful of what's in the press and what isn't, is that in Holland and America, it wasn't just tyres that were used in the rubber crumb surface. So whereas we, through the Football Association Football Foundation, have insisted it's a certain tyre that's used, there was other rubber that was used in the surface of the pitches. And I think that was the initial glaring press release, that it wasn't tyre, it was from other substances that rubber was used and crushed and shredded. But that is work in progress. The Sport England Football Foundation, all the national bodies are looking at that and doing some further reviews on that and some health testing. The last one I've got, and I do apologise, I didn't print 15 or so copies of. The team have been working very hard, and again I refer to John Linans, around social media and digital marketing. We're very conscious that young people these days don't look at a newspaper, everything has to be through their mobile phone and device. And we are, and have been working behind developing a platform where we can promote that, all our services, along with also clubs. Again, I will circulate some more, but what I have done is just taken a snapshot of some of the development we've been doing and will be launching in the next 2 or 3 weeks as a soft launch, and working with clubs so that we've got a club notice board. So organisations in the borough can use our notice board to promote and publish and sort of tell a wider group and all the other groups about what's going on. We are pushing through Facebook, Twitter, LinkedIn, all our services, and I just put a snapshot of the sites that we've been developing over the past sort of 6 or 7 months, and I'm quite happy to circulate those. The last one I've got is that I'm very conscious in terms of outcomes, that we sit here and we can talk about numbers, but I think there's nothing more enlightening than actually seeing some customers that have actually made a significant turnaround. We appreciate that we've got an ageing population in the borough, and we've got a number of community groups and community classes and partners that we work with. And what I have got is a short video of some clients that actually agreed to be videoed while they're actually doing a session. And it was just, I just wanted to spend 2 or 3 minutes and show that to you, instead of adding further paperwork and saying this is what A said, this is what B said, and I thought it was much better to do that. Hopefully the sound will be loud enough.
We'll have to dub it.
So I'll carry on talking. So these are referred through public health. They're partners that we work with through the Fitter Futures. A lot of them have had surgery. So will be cardiac patients, stroke patients, etc. If not, I'll post you a link. Thanks, Shirley. I can give you a direct link where you can watch that and listen to that on your own PC time. But we've got 2 clients that actually sat there and said, yeah, we'll feed back on what we've actually achieved by working with you. But I think sometimes it's just nice to see a face behind that and actually hear that from themselves. Thank you, Chair.
It's obviously the sound. Kevin's going to send it out to you. So. Conclude the report, Kevin.
That's it.
Any questions from members? Oh, sorry. This is fun call.
Thank you. You haven't touched on it at all, but I mean, I know I've gone on about it quite a lot and things, but it does really concern me still. The climbing tower, because this has been dragging on and on. It was actually purchased in September 2015. It was agreed in June 2015. And so we're sort of 2 years on from the decision to purchase it. And a lot of the issues, you know, about the towing of the vehicle, its size and all that sort of thing, you know, really should have been considered, you know, beforehand. So one of my questions is really, why are we not retaining the staff? Because you did get staff to you know, take it out and things, and for whatever reason, which I'm interested to know why, we've not retained the staff to actually take it out. I mean, yes, it has been at, you know, some events and things, but the carnival was the classic one. I expected to see it there, and it wasn't there, and there were, you know, so many people, it would have been an ideal place. So on your team members, you have got a sports coach climbing. Obviously one person on their own can't, you know, take it out. So I'm sort of really questioning what the situation is. What is this person who is there for the climbing doing if they're not able to take it out on their own? So how else are they being employed and things? And you know, because of all these issues and difficulty getting people to, you know, be employed to take it, you know, be climbing instructors or whatever, you know, what are you not sort of thinking, oh well, this hasn't gone right and things, you know, cut our losses and, you know, sell it, hand it to someone like the Scouts who, you know, would be able to use it and things. And the other thing I wanted to raise was 7.1. Now I knew about this sort of website thing, you know, coming on and things, but I'm just a bit concerned here. It can be developed promoting all the local cycle routes with the new cycle club being developed. What new cycle club? Because there was no mention of the new cycle club at the cycle forum, and obviously I do a lot of cycling, and I just want to know what that's all about.
Any members got any points of clarification? No?
Okay, thank you, Chair. If I take the second one first, the cycle club I'm talking about is Velos at Ambleside, which obviously we're talking about last year, so it's 16, 17, and we've been working with those to see how we can work with those further and develop some additional resources in terms of delivering cycling. That's the cycle club, and we're looking to see how we can work with them into the future, developing that. In terms of your first query, yes, I as the sports development manager, had difficulties retaining staff. We recruited, we commenced delivery. Unfortunately, then we lost two of the delivery partners later on last year. We didn't start delivery until April 16. The decision was purchased. Decision was to purchase the climbing tower in 2015, but we didn't start delivery until April 2016. I think that was in the outside of the museum was our first event. Unfortunately, because they're part-time hours, what we have done, or what we have found, is we've recruited, we've trained them, we've got some delivery, and then they found a full-time post. So they've come from either unemployment or casual hours or 0 hours, and we've managed to recruit them, and then we've developed them, and then fortunately or unfortunately, they've then been able to secure further full-time posts. And again, quite recently, we lost a second tranche and we went out to advert, and unfortunately we did not get anybody that met the person's spec. So what are we doing as we speak? We have recruited 6 essentially NBBC employees on casual contracts from the depot and throughout the town hall and other partners close to the Borough Council, and recruited and are training those currently to help us deliver the tower. We delivered the tower last weekend at Bulkington because we had resources to do that and we had a qualified driver. I think the expectations in terms of health and safety is that I will, and I'm very conscious that that is a 10-metre tower, and we need to make sure we've got the relevant qualifications and competencies of a driver who can tow that, because it's a very long vehicle. It's as long as a dustbin lorry, and then you've got the towing vehicle in front of that. And that isn't a skill that everybody's got or everybody likes to do.
Well, that is what I might have applied for the job if it wasn't for that aspect.
So we have been ensuring that we employ and recruit the right people that have got those skills, because unless they've got that, then I'm not comfortable in terms of health and safety that they will tow the tower for us. We're currently looking at other avenues for that tower and are very close to having that tower delivered with some other partners, and working behind the scenes to try and get that out as quick as possible. We have got a programme now planned for the summer, but we're looking to extend that and add to that as we speak. But I'm not denying we have struggled to recruit and retrain. We have recruited and we've lost those individuals because they've moved on to full-time posts. And we're currently trying to recruit and develop people in-house. We've had a very good response from our colleagues at the depot that have got those driving experiences, but likewise they still need to be competent in towing that vehicle, and they need to be checked to make sure, because it is a trailer vehicle.
Councillor Ellis.
Thanks, Claire. I've got 2 things. The first one's a nice, easy one. You said that you don't advertise in newspapers. There's some brilliant things going on. Did you say you don't advertise in newspapers?
No.
For social media?
Sorry. No, we do. We put editorials in and we put them on our social media sites and also the Borough Council's website. We will send them to the press, but they're not guaranteed to be put in. But we do use that medium as well.
Okay, well, the point I was going to make is that you say children prefer online, but their parents quite often prefer the newspapers and then see things like foot golf is available and take their children down. So I think that's an avenue to still pursue. And the second one is around the 3G. Thank you for all the investigations and the assurances. You said it's ongoing. thing that I would like to raise is the research you've pointed us to has come from the FA, who have cited numerous independent scientific studies. Now, anybody else that produces a report has to give their sources and their references and state what those scientific studies are. The FA haven't, and I can't find them anywhere, so I'm not comfortable with that reassurance as it stands, so I'm happy to hear that it's an ongoing issue.
I think I can only give you the reassurance that I've got from the organisations that have funded those pitches. I think the FA and the Football Foundation that have around 200 million a year to develop and grow football, and a lot of that is put into third generation pitches, are also concerned, which is why they're following on the investigation and making sure. I think at this time that's the information they've got on the health studies. That's not to say that that won't change, but what I have asked is that I'm constantly updated through the regional manager on any statements that come forward.
I just wanted to ask about potential opportunities for the park room. Again, I know you're probably getting fed up of hearing about this. I seem to recall the last time this was mentioned was at one of these committees, that someone, I can't remember if it was yourself or not, said that an opportunity was potentially being explored. I just wondered if any further research had been done with that.
There is. It was in February. I did mention that, and I was asked on park rooms as to why the Borough Council or the Nuneaton Bedworth haven't got them. We're working closely with Coventry City Council, who are looking to put one at Longford. We were looking to put one in the Miners Welfare Park, which we said, hang on a minute, this is going to pull against each other. So what we're looking to do is, Coventry have already got a number of park rooms in Coventry and Northern Park. So we are currently working with them to see whether we can, Nuneaton Bedworth can take that for the Miners Welfare Park, and we're looking to see whether we can develop that. We have 2 volunteers that have come forward and said they are very keen to take on that, but we need between 6 and 8. So we are looking to work with Carver and their Warwickshire and their volunteer worker to see how we can recruit more volunteers to take that on. So as the Borough Council, we would support that, and I think the work that's going on at the cricket club in terms of the facilities there would be an ideal venue using the surrounding area to develop a park room. But also we've talked around Whittleford Park, which is a bigger site than the Miners Welfare Park. So we're just waiting to hear from Coventry in terms of those discussions as to, we don't really want to compete because they're quite close. We'd rather that we work together and sort of promote that between ourselves. So that's the current up to date where we are with Park Room, but we are very keen to get one for the borough. Similar that we've instigated a 10k run for September is that other boroughs have them and we haven't, so we're trying to make sure that we put ourselves on the map.
Any idea on timescales when we might?
I don't. What I will do is I'll follow up with my colleague who's liaising with Coventry City Council, Jonathan Hunt, who's their sports development manager, and see where we are with that. The earliest it would be now would be the end of the summer, because the training by the volunteers, because there's a package in place that's put in front to train the volunteers, and then it's a case of recruiting volunteers to keep that up and running. But we would support them, but I think the earliest would be the end of the summer, to be honest. Okay.
I've got quite a big list. I'll start with the good news. It's good we've got the cycle racks in downstairs for staff, but it's not being used enough. And I understand we're looking at getting showers in the council house to try and encourage staff cycling, because as we were talking about in the John Renane's presentation, our life expectancy is quite low, and people who cycle to work get 2 years more life expectancy. So it'd be really good to be progressing cycling for the staff. On the work you're doing with things like walking for health and things, it's really good if we can actually start progressing people into their mainstream walking classes, or sort of not just have it at the dead end and they do the 1 mile around the park or 2 miles, actually having a progression for those that want to actually to go up a step of exercise. Also, it's useful to look at different exercises because you need mass participation. And one thing that's quite often, particularly older people, is like the tea dances and the dancing type thing. I mean, there's lots of programs about dancing, so I don't know if the sports development are thinking around some of these other activities to get people who don't usually take part in sport to get involved. And quite a lot of the stuff you're doing is the refurbishment of Bedworth Cricket Club, not criticising it as a good project, but we're not getting these projects in Sandon Park yet. And you mentioned Whittleford Park as a park run destination. There's actually so much more need up in places like Camp Hill, where we actually aren't doing anywhere near as much as all the stuff that's going on in Bedworth. Final point, if we're taking the depot drivers off to do the climbing wall, is this contributing to our problems with actually doing the big runs?
Perhaps I could answer that one, because that in there because it's not training,
Chair, I'll try and answer all those. The cycling facilities, I'm pleased to say that following the employee survey that was done last year, the showers will be finished in the next 2 days, which have been put in place. We have a partnership arrangement with Warwickshire County Council where we've got 2 Bromford bikes that are in the cycle store, and they've been available since it was late last summer for all staff to use those for meetings throughout the borough. All the safety equipment is downstairs as well. One of the feedback we had is if people use a bike, then they want somewhere to change and have a shower. Hence the reason why that was being developed. So I'm pleased to say that the showers, once finished, available for obviously all employees, members, etc., will give the opportunity for employees to then use those and use the bikes and probably bring their own bikes in as well, and have that facility to encourage more people to use bike, even for local meetings, etc. So that's something that we'll be looking to push as soon as the showers are handed over through building services team. In terms of the walking, I'm pleased to say that we do the measured miles, and a number of those volunteers do additional walking. So they have a number of events where that be social, and they do other coached events where they'll go out for a whole day of walking. So there are opportunities to do those stretch miles. So it's a 1 mile, 5 mile, 7 mile, 10 mile, and that's a real network of social facilities for that age group and those walkers, and that's really been developed with the volunteers and other people that have taken on hiring coaches and do those trips out. In terms of the mass numbers, we've had some success with walking football, with touch rugby, where we're getting numbers of 100, 120, and we're looking to see how we can develop that. But as I say, the 10k, the park run is something that we do need to put in place to support that mass participation. In terms of the climbing tower, I'm pleased to say no, that isn't the case, because most of the delivery would be afternoons, evenings and weekends. So the drivers that we are using, it's outside their normal operational hours, so it doesn't have an impact on other council services.
Thank you, Chair. It's good to hear about transforming the lives of some of our staff. That's some really exciting news. I'm sure there are a few of us members who could lose do we losing 7 or more stone. In relation to how we engage young people, while Facebook is really useful, and I welcome the documents you've given us, although Trudy has got 2 notifications, I wonder whether we're using Instagram or obviously Twitter and things like that, because young people, I'm not young, I haven't been for a long time, but young people, my understanding is they don't really use Facebook as much as they did previously. So even my students who are 18-year-olds plus, they're using what's the one where you do a quick recording? Snapchat. So I wonder whether we could maybe do something with Snapchat to say, give a bit of advice or a workout before you exercise or do sports, or a glimpse of what we're doing, or I don't know. There are lots of mediums, and I just wondered how we develop those. Finally, I also wondered, I actually think dancing is really good. I don't do it, as you can tell, but actually engage with young people and people sort of in the middle age ranges as well, because there are different forms of dance that can reach out to the whole community. And I just wonder what different forms of dance or different activities and sports we were looking at developing to reach out to the real diverse community that we have in Nuneaton and Bedworth, because obviously there are small groups who really use and take up the opportunities that we offer, but it's about how can we reach more people, really. And finally, I'm pleased about the showers, in particular, that members will be able to use them, so that would be fantastic.
Thank you. Chair, sorry, did you want me to respond? Just quickly, Twitter and Instagram are included in what we've developed, so we've got those. It's just a case of we've got to make sure that's fresh and that's useful for young people. So that's a challenge we've got in terms of making sure that that's ongoing. But we have Twitter. I haven't put Twitter and Instagram, but we have developed those as well. In terms of dance community centre delivery, we're currently looking at the leisure community centre strategy that was adopted in January and looking at the priorities for that and how that stems from the Borough Council going forward, because that looks at the current population and future population. That also looks at Sport England's data on what that population is for us and in terms of where our growth areas are. An ageing population is one of those. There are a number of pen portraits, they call, in terms of classifying residents of the borough, and Elsie and Arnold is the 65 plus category, and that is a significant pen portrait now and going forward. So we're currently looking at that as to what the key priorities are, and it will be around what those priorities are and what we can support. I think in terms of dance, we would be looking to work with partners to encourage and develop more of that, because unfortunately Sport England don't class that as a sport, and consequently there isn't any funding and support behind that. That's not to say other partners would, so by all means I'll go away and obviously look at that and see where that head's going forward.
Chair, finally, sorry, I also wanted to commend the work around girls football. You know, we actually in this borough have got somebody that we can celebrate in Laura, and really we want young people to aspire, and they've got to have those opportunities to rise through the ranks. So it's a great starting place, and I'd like to see it kick off and then maybe expand through the borough. So I'm really excited about that.
Any other member?
Just one bit you never, if I may, Chair. I mentioned Sandon Park and what's going on with the other centres that haven't got this big boost like you have at the Bedworth one at the moment.
Okay, Chair. That refers to the last answer I gave in terms of the playing pitch strategy that the Borough Council adopted in January. That's looking at the priorities in terms of pitch provision. I think members that are on the working group were shocked to see that we had 102 football teams several years ago, and we're now down to 40, 45 plus senior teams. So that sort of says we've got to look at our facilities and what we need going forward. Sandon Park is a key area for football provision. There are 4 pitches there, changing rooms, small car parking, but I think depending on the outcomes of the working group, that would be a site that they'll look at going forward. I am aware that the housing development in Wellington, the parks have secured some funding to look at refurbishing the Sandon Park facility in terms of changing rooms, but they are changing provision. Essentially it's like 6 changing rooms with toilets and officials' rooms, so there's limited ability for what they can be used for apart from changing facilities, but that's something the working group are looking at in terms of its priorities.
I think the point that's worked so well in Bedworth is you've managed to leverage some money and then get some more money on top of it. Well, yeah, so a bit of this, a bit of that money, and we're not getting that in places like Wellington. So it would be useful to look to make sure we can actually use the Section 106 money and see if at the same time as doing those works, if we can actually say match fund it with some other type of application, because we are not getting the money in Wellington for sports facilities. We're getting all the houses, potentially 4,000. And we're not getting facilities. We see the facilities, marvellous facilities, not complaining about them as such going in on Bedworth, but we actually want that to be the model of what we do elsewhere.
I presume that's what the working group are looking at.
They will do, and Chair, just one key item is around the groups working and having the strength in their management committees to be able to do that. The success of Bedworth Cricket Club is that they've got 4 members that have really put a lot of hard work and effort into that, and a number of clubs have that volunteer capacity, but it needs 2 or 3 of them to step back from their day-to-day delivery of coaching, running the club, and look at their future development plans. And that's something we are working with clubs with, because they need to have a future development plan as to how we can get to that. It doesn't just happen. Bedworth Cricket Club will work for 5 years to get that funding in place and their development plan, but what we need to do is encourage those volunteers that are in some of those clubs in Nuneaton to see where we can get them to a point of looking to develop their facilities.
Item 6 is improving stroke services. Andrea Green doesn't seem to have turned up. So can I ask the members' wishes in terms of the report?
Chair, could I move that we defer the item, if that's okay by the Chair, and find out where our guest has gone? Because we don't know why he's not here. But I think it's better to receive a report from the person directly.
Well, I understood there's actually consultations going on until the 16th of July, so deferring it doesn't actually give us a chance to then respond as a committee. So I don't know how we could do it online or something, or where we're going, but I don't want to not respond to the stroke package.
Well, I've ever worked through the report as best we can, and obviously with not being able to ask the questions we need to ask. This is probably what you've asked us to do, so if you could do it before we move into the debate,
Yeah.
it'd be easier.
Well, there were just a few things that sort of came up from having read through this stroke stuff. I mean, I'm all for, you know, having sort of the top best treatment and things, and I understand, you know, that may well need to be, you know, in centres like Coventry, but it was the issues about people getting there, and particularly visiting and what have you, because, you know, parking at Coventry at the UHCW is a complete utter nightmare. Anyone who's been, you know, will tell you that. And in the paperwork it mentioned that there was public transport between George Eliot and UHCW. Well, yes, so limited, and I'm not even convinced that it actually goes from the George Eliot to UHCW. I think it goes from the bus station to UHCW via Bolkington and various other places and things. So that is a huge issue. The actual time it takes, the services, and actually the cost. And, you know, yes, you want to have the best possible treatment, but it's weighing up all the, you know, issues from both sides. And I was hoping that, you know, someone from the CCG would be able to sort of say how that they had, because they say, oh, we've looked at that, you know, that is an issue that's, you know, come up, but because they actually, really with transport, they actually need to have some absolute commitment with bus companies or whatever, or some sort of shuttle between the two hospitals for it to work, as far as I can see. But we've got no one to ask. I will be going to the CCG meeting next week, which is public, held in public, so we'll try and get some answers then.
Members got any points of clarification? No?
Vice Chair? Can you just clarify exactly when that meeting is, because we can all tell.
It's next Thursday, so that's the 13th. So it's only just before the consultation finishes. It's at Heron House, second floor, which is the one by the little batch bar over. I can't even remember which street it's in. Is that New? Royal Abbey Street. Hold that thing. 10:30, and it's usually till about 12:30, or often finished a bit before. It's not a public meeting, it's a meeting held in public, but there is always opportunity at the end for questions.
Let's move on to the report. Has everybody read this? Comments?
Well, I picked up the same thing as Mrs. Kandaka about the public transport. The bus that goes out to the Walsgrave, it actually runs, I think, or when I looked last, every 2 hours, and it's run by De Courcy Travel, so people will not be able to get a ticket from Camp Hill. They'll have to change operators. It is a right pain if you haven't got a car. You have to rely upon a friend to take you, and a lot of people, it would actually be easier to have a stroke unit in Birmingham, which is physically a lot further, but potentially could actually have a through integrated train ticket, bus ticket, everything, than actually trying to get to Walsgrave, which is coming. The stroke here, we're not just talking about Nuneaton and Bedworth, we're talking about the provision for North Warwickshire, so we're talking about the Averstons, all the way up. I don't know where the next stroke unit is going north, but it's a very large area, and Walsgrave is so disconnected. The other thing, obviously, we need to do is to protect services at the George Eliot in terms of the financial viability. So if we are moving specialist services to the Walsgrave, we should be trying to insist we move more general services from the Walsgrave back to the George Eliot. So actually the throughput is, the hospital's still viable in terms of the George Eliot financially, and you're taking some of the car parking pressures off the Walsgrave. So much stuff goes to Walsgrave that it's just general medicine that really should be repatriated to Nuneaton.
Yeah, unless I've got my figures wrong, I know that there's some proposal to actually increase the prevention of stroke and thus reduce the number of beds that are required. But by my reckoning, currently there are about 93 beds provided across the piece, and the proposals actually come to 82, if I'm right, but there's quite a reduction in beds, and I can see the benefits of having specialised units and specialised skills, but it doesn't really address the capacity issue. They seem to have skirted over any issues about capacity, and I know eventually they want to reduce the need for the acute beds, but initially one would have thought that there has to be an equity. If it is going to be provided at Coventry, it seems that the proposals are initially to reduce that number of beds, and I think we need to have some perhaps narrative around how they evidence the need for that percentage reduction in beds.
Thank you, Chair. Just a final point about transport. It does actually take an hour to get from the Nuneaton bus station to the hospital in Coventry. If you have child care arrangements, then it's actually quite difficult to follow through, because one, it depends how long you're at the hospital, and then you have to wait for a bus and then an hour back. So you literally have to rule out the whole day if you go to the hospital for anything. They want to turn George Eliot into a rehabilitation service. Now they've specified that Coventry has the most up-to-date facilities and that staff are the most up-to-date there. Now, if you take acute services from George Eliot, you'll lose your staff, and who then runs rehabilitation? Because the staff who remain in George Eliot will lose their skill. So that's an issue. They've also said specialist stroke rehabilitation in patients' homes as required. Now, if people live on their own, if they live in a second floor flat without a lift, then if they've had a stroke, that is not going to happen, which means that they have to be in George Eliot, which automatically messes up their numbers because they're really not focusing on on patients who actually can't be at home. So I don't think their numbers quite stack up.
Any other member? Councillor Ellis.
I just want to reassure those that are concerned about transport that on page 21 they are going to look at the transport needs. They're going to provide a leaflet about transport options.
That's really helpful.
You're welcome.
Let's speed the buses up.
Any other member? I think a couple of things I've picked up is one in terms of the consultation deadline. Usually they usually statutory of 6 weeks and this is only 4, which I found very surprising because it doesn't actually give people much time to respond, does it? Especially in the holiday period. So it's usually 6, so I think we need to mention that from the right. I have got the same issues everybody else has got in terms of transport. I mean, if the stroke patient happens to be the sole driver, straight away you've lost the driver that would actually get you there to visit. It's very important for stroke patients, as my father had a stroke, to have family around them so that they can recognise faces in some cases. So the transport for me doesn't stack up and ask for a leaflet, wow. So, because I know it doesn't go from the alley, it goes from the bus station. It's certainly, the last time, it was about every 2 hours we go. So if you miss one, and I think they finish about 6:30, so how are you going to get home, I'm not quite sure. And in the area of high deprivation that the borough sits in, I don't know if the residents would be able to afford to go backwards and forwards. I think that's a real impact it's going to have on them. So what are members' wishes?
Can I suggest we actually write a letter to respond to the consultation listing all the points listed by members?
Happy to second that. Would you like me to get Shirley to draft a letter up and send it out? People can check it, see if there's anything else they want to add, and then we can send it off from this committee.
Obviously I've made a note of what's been said, but if anybody wants to send me emails with specific comments, then I can look to include.
Can I suggest as a short deadline? So anything would need to be back to Shirley by Monday at the latest, because it's 16th of July, so it's going to be sent as well. So
there's also, Chair, an actual questionnaire at the back. So clearly the CCG would be happy for anybody to go online and complete that.
So can I suggest you all fill in the questionnaire as well, because obviously the more responses we get from the Borough residents, the better. The other thing I was concerned about, I just noticed, is the 2 case studies that weren't very balanced. Purely on let's move it to there's no balance in there in terms of what other people said, and I'm sure other people said no. But exactly the balance in the document is pretty poor. Comments, I'll move on to item 10. The SPP, I've got no updates this current time. On item 11, I've got no updates from the Borough County Council because their first meeting was when we had full council. And actually I haven't been in front of council. The work programme, item 12.
Thank you, Chair.
The items that we have in the agenda on page 76 are the items that were left over from last year. Obviously, the bottom on there, provision of hospice beds, is has come tonight. So
and they've asked for that to come back at the time, in 6 months' time. So it's starting in September, so it'll be
yes,
March.
Yes, I've written that down too. I don't know, the stroke services, it's been a bit of a funny one, this. They told me that they were going out to consultation and they requested that they come in September with the results of the consultation to this committee. So that was how it was left, and I had originally put the stroke services on here for your information and so that you could look at the document and make comments into the consultation if you so wish. I then, about a fortnight ago, got an email from the CCG to say that Andrea Green would attend tonight and speak to you in regard to the consultation. So I'm not sure what's happened. And now I'm going to need to check, is she going to be coming in September, as originally planned, to tell us what's happened with the consultation that they've received. They did say, as I've put on there, that they had to put it through the inspector, and that's why they wanted to leave it till September. Is there anything on this work programme from last year that's come over that you don't want to bother with anymore, or are you quite happy for all those things to stay?
Remember? I've said that consensus, you're happy for you all to stay.
Okay. And from this evening's meeting, obviously we've talked about the hospice pilot, which was March, as you say. We also talked about the suicide prevention strategy, and Dr. Nuneaton said he would be happy for a member of his team to come and do a presentation on that if you wanted that. And then there was the health store, which you requested in September, so that we could have an update on the funding and the service that was going to be provided there. So we've got those to add. The stand-in programmes that tend to be on our list for the year are usually an annual update from George Eliot Hospital. The chief exec usually comes along and gives us an update on that, so that we can retain if you wish. The JSNA, which you've had this evening from Dr. Nuneaton, is an annual thing. Usually around this time of year we ask for that, so that was why that came tonight. Kay Green talked a lot about end-of-life care as part of her role as hospice. But actually end-of-life care has been on our work programme annually for a number of years, and I have already arranged for somebody from George Eliot, I think it's a Dr. Wood, to come and speak to you about end-of-life care in September, I believe. It could be November, but I think it's September. We've also got an arrangement already made with Health Watch, who are going to come along. And then Kevin, obviously, with his sports development, I don't think we said whether you wanted him back in 6 months or whether the annual report's sufficient. But I think we're doing something around performance, aren't we, with Kevin? Trying to put a bit of action plan, sort of half-yearly performance report, if you like, so that you have a monetary report to come in, and Kevin will feed into that. So if members are happy, I can add all them back onto the list for the coming year, and which will start you off with a good sized work programme. We've also had 2 additional items. One from Councillor Elliott on autism, and that sort of linked into, I believe, the CAMS and mental health service that came at the end of the last municipal year, sparked off your thoughts about, well, perhaps they need, members would benefit from knowing a bit more around autism and how that fits in. So Councillor Elliott has offered to do a session for members if you're interested. So we've added that if you want to add that to the work programme. And then, as has been raised tonight, Councillor Kondarkar has asked about what the provision of GPs and health centres is going to be as part of the new development and planning stuff around the borough. So I would assume, or do you want to include that as well?
So in terms of Councillor Elliott's work programme, I'm actually happy for that to go forward in terms of autism. It might be November, because I'm wondering whether maybe we could have CAMS at the same time, if the change in provider, because that might help you feed into CAMS as well.
One of the reasons for suggesting it is that the last OSP we had, members weren't really aware of what autism was and what's happening at the moment with CAMS, and Dr. Linnane said that attachment disorder, which is the diagnosis being given instead of autism at the moment, and lots and lots of issues. People don't really know what it is. So I give training in that where I work and other places. It won't really be an hour long, that's just to include some time for any questions at the end of the chapter like that.
Happy that to go forward? Councillor Collins, of course, in regard to the GPs. Happy that to go forward. The other thing, if going forward, the other thing I'd like to add in is obviously having the CCG input in terms of the demand, the provision, the looking at, also about the training of GPs and recruitment and things, because I think that would be useful to slot in at the side of it, because obviously if that's out of our remit, we'd need to know what they're doing, because I think John Linnane said tonight that, you know, they've got an issue with recruitment, so that's our way of
That's important.
so everybody's happy for that to go forward with the extra bits on the CCG going in. Well, that with yourself as your work programme item.
And just as a slight aside, and I'm looking at Margaret here because I know she'll be interested. We've got something a bit misplaced in the agenda. On page 36, it does say agenda item 7, but it doesn't actually relate to the public health update that we had. This is the response. If you remember last year, we wrote to the Education Secretary,
Yes.
Greening.
Justine,
that's right. And this is the response that we received just shortly after the election this year. So that's why that's there. It's not anything to do with agenda item 7, but I think it just got caught up in the paperwork there. So I just wanted to draw your attention to that. So, on that meeting, Chair.
I've not been informed of any other items, so thank you very much for your time. The next meeting is September the 7th. Thank you very much. There is healthy options over there if anybody wants any.
What might be useful on the agenda is to put the name of like, the guys, the woman from Marianne. If you put it in the minutes so we know who people's names are, because they didn't have it on the paper.
We've got, just so that everybody knows, this is our new committee clerk, this is Wendy. So she's still training up. So there are one or two things that, because everywhere does it different.